Good morning, everybody. Thank you for waking up so early and being here. I think the discussion that followed at the end of the last talk really sets up my talk. And this clinical dilemma is very frequently encountered by physicians across the board in the United States. And another ethical issue that has come to light lately in the United States is refusal of patient care or refusal of dialysis by dialysis providers because the patient happens to have a tunnel dialysis catheter. And that's, again, it's a problem because the patients have a right to choose. And I think our job as clinicians and as providers is to educate not only the patient, but also the entire family which surrounds the patients. And sometimes just constant education and giving them the facts like they are really helps to get that patient moved from that fear of surgery, the fear of failure, and then get them up to better outcomes and better access care. And the role of a vascular access coordinator fits right into that place to get that patient from the problems that we see in dialysis. And dialysis is a very difficult life. And one of the things that I tell my nephrology fellows is, your job as a nephrologist is primarily to prevent dialysis. And that's a huge conflict of interest if you think within our own practice. We are providing dialysis, but our job really is to prevent dialysis and prevent these patients to get onto dialysis because there are no easy choices on dialysis yet. Even transplantation has its own set of problems, and that's the best that we can offer the patient. But yet we see that the prevalence of dialysis is growing by leaps and bounds, not only in the United States, which is right on top, but all over. And there is no data available in published series at USRDS or other places. And the best I could gather from talks yesterday, we are about 800 to 1,000 patients per million, which is a very high prevalence in this part of the country as well. And it seems like when you weed out the dialysis patient and try and describe them, most of the dialysis patients, at least 1 out of 3 dialysis patients, have never been to high school. This is in the United States. And I'm sure those numbers will track very closely in India as well, that a dialysis patient comes primarily from the poor socioeconomic background with a very poor education level and does not really understand what is a fistula, what is a catheter, what is sepsis. But those are the things that we throw at our patients, and we want them to adapt a catheter, which is the best access according to the patient because they get onto the machine fastest, they have no needle sticks, there is no pain, and they get off the machine the fastest and they go home the fastest. So there is a conflict there in terms of what the patients want and what they should get. But when you look at education, it does translate not only into outcomes, it does translate into death. If you have no formal education, the risk of death is almost 2 times higher compared to patients who are educated and understand what their problems are and are able to take informed decisions along with their providers in managing their clinical situation. So education has come up to be a huge positive empowerment of the patient that we really need to focus on. When patients are initiated in the United States, the average time for education is about 10 to 30 minutes. So what we try and teach our nephrology fellows in months, these uneducated patients are getting in 10 to 30 minutes. That's a crash course. In that 10, 30 minutes, they're told about transplantation, they're told about vascular access, the dialysis, the sepsis, and that they need to come these many times a week. They need to have this much fluid intake. This is what the food intake should be. This is what they should eat. This is what they should not eat. What is a binder? What is erythropoietin? What is iron? This is all in 10 to 30 minutes. So maybe we need to go to the dialysis units and get educated. When we look at any database, and this is one of the very first database that kind of highlighted the problem, that vascular access directly affects mortality. So when you compare patients who have AV fistula and compare them to those who have an AV graft or a catheter, the risk of death is 2 times higher. 2 to 2.5 times higher risk of death, 2 to 2.5 times higher risk of sepsis, and infection-related mortality is the #1 problem by which the patients are dying. So the vascular access is not what we are focusing on. We're just focusing on dialysis provider, which is one part of the problem. And we are struggling with the high patient-to-physician ratio. We have a very low nurse-to-patient ratio. In the United States, we are using a wide variety of physician extenders, whether they are nurses, physician assistants, and these are the people who are rounding on physicians' behalves. We have fellows taking care of these patients. And there is a high turnover of dialysis providers that are actually in dialysis units. So there are multiple missed opportunities where we do not have a process in place to really focus on vascular access, and that's why a vascular access provider is essential, because your #1 mortality in dialysis is related to vascular access. So this concept of vascular access coordinator really first was published by Michael Alon, and Michael Alon is a good friend of ours and is a very active proponent of vascular access outcomes at both ASN and ASDIN forum. And they started seeing a very high number of AV grafts, very high numbers of catheters. The care was very fragmented. Patients were staying in the hospital for several days when they had problems with their AV access. And there were no good pathways developed in trying to get these patients better care. These were the vascular access breakdown, if you will, with a very high number of AV grafts in their population, and a very high number of AV graft dysfunction, thrombosis, and recurrent return to the hospital. So the first thing that they did was they created a teamwork, and they put a vascular access coordinator who was a physician's assistant with a long experience in dialysis care, and they charged that person with specific jobs where they would schedule those patients to come into and get their access examined or taken care of. They would communicate between the patients, the dialysis units, and the surgeon's office, the interventional radiology office. They did not have an interventional nephrology program at that time. And they will get those information from those office visits back to the dialysis providers. And that's another big missing piece at times. The surgeons say that this patient needs a revision of the AV fistula, but that never goes back to the dialysis unit, and the patients are still waiting to figure out what needs to be done. And this person was also tasked with constantly monitoring the outcomes of dialysis access, and then looking for problems with that patient or with their practice, and then coming up with interventions to try and can address those. So what happened after they had this program for about a year? They saw that the thrombectomy rates went down a lot, and more importantly, these thrombectomies were now done in an outpatient access center where the patients went in the morning, they got their procedure done, got back in the afternoon, and went back to dialysis the same day. So the cost of care goes down. They focused on the total graft thrombosis rates went down by 44%, and their AV fistula rates went up. And the same model has since been replicated in several practices. So in terms of data, does this work? I think we have very clear data that having a vascular access coordinator is essential, is central, and is probably the missing puzzle in a practice where we are seeing very high rates of catheters or very high rates of failing accesses. So how do I use the vascular access coordinator at LSU? So we have 2 vascular access coordinators. They are not full-time vascular access, but they have a very designated scope of their work, which is focusing on vascular access. And the number one thing that they do is they are those patients' communicators. They are the patient's voice in terms of what is happening there, and they will frequently text me, they'll email me, they'll page me if they have issues with their access or any of the, we have 5 interventional nephrologists at the LSU practice now. So anybody there is one person who's always on service at interventional nephrology. So that is a person that will be contacted for any problems with these patients. They are educating these patients on vein preservations in our clinic. One of the coordinator works in the clinic as well. So CKD access education is important because the incident utilization of AVF across the country in the United States is still at about 20% or so. So only about 1 in 5 patients that are starting dialysis in US are starting with an AV fistula. The number is even smaller here. In our practice at LSU, we have about 1 in 2. So about 50% of the patients that are starting dialysis are starting with a fistula. And I think some part of it is attributed to the care that's provided in the CKD clinic. These patients need to go and get preoperative workup done before they can go into the surgery clinic, so that needs certain coordination. And once that's done, the coordinator 2, who is primarily in the dialysis units, is looking at these access and making sure that there is an adequate outcome of that access, and if not, then those patients are referred back to our patients. Every dialysis unit has active monitoring and surveillance program, but frequently, if that's not something that is looked into, then things may be missed. So the vascular access coordinator who is in the dialysis units every week, she's looking at that data. And then one other job for the coordinator is to try and put all of these data together and then see how we can ask certain questions which will help improve patient outcomes and quality outcomes for our patients. Being a patient liaison is a very important job because kidney problems are complicated. These patients have multiple comorbid conditions. Do they have congestive heart failure, which is going to make their AV fistula a difficult job? Do they have transportation available? Are these patients in a nursing home? How are they going to get to the surgery office? Are all very important issues. How aware is my patient? And that's where the education part and the time that you need to spend with the patient comes in. And you really have to have someone who can talk to the patient at their level. And I think physicians are probably the worst in terms of their ability to do that, where you can get to the ground, sit down with the patients. Most of my fellows, when they go talk to the patients, they stand up. And they'll be standing on the top and they're talking down on the patient. And the patients have a fear of the physician. They're not going to ask any questions. They're not going to clarify any doubts that they have. Just the act of sitting down, pulling a chair with the patient, holding their hand, and asking them the right question can sometimes give you a lot more information from the patient. One of the frequent complaints is I just asked this patient this question, they never told me about it. And you go ask the same question to the patient again, and now they'll feel more comfortable in telling you that problem. So that coordinator who can really go to the level of the patient and discuss that with the patient makes it a lot easier for that patient. The post-op follow-up, I kind of alluded on that earlier. You need a way that you could examine these access. So at LSU Shreveport, we have about 400 plus ESRD patients, but there's a big private nephrology group in town, and they probably have about 1,200 odd patients. And frequently, we'll see patients referred to us from their practice, and the access has been there for a year. And nobody examined that fistula, which was immature, had a very simple problem that could have been fixed 8 months ago. The AV fistula would have come out, the catheter would have come out if he had fixed that inflow problem or a stenosis in that patient. But you wait that long, that's always going to be exposing the patient to that higher risk of catheter-related infections. In a CKD patients, if you place an access before or get an access placed before they initiate dialysis, We have ways to do angiogram with CO2 angiography so that you minimize exposure to contrast, or do minimal use of contrast. Frequently, you can do a full angiogram with less than 10 cc's of contrast. On an average, I would do it with about 5.5 in about 50 odd patients that we pull data on. So 5 cc's of contrast is not going to cause any contrast injury, even if your GFR is 18 or 15 to begin with. So these access, like I said, the coordinators are monitoring, and the dialysis units have a surveillance program, which then gets reviewed by the rounding provider on a weekly basis, and then acted on based on what the numbers show. The opportunities are to improve outcomes for the patients, but also have ways to incorporate new technology, new research. We've had a few trials where we tried to look at outcomes of fistula outcomes based on a study by Proteon. So these patients were involved and incorporated in those studies with the help of the Vascular Access Coordinator. And then these coordinators would go back and follow up on those patients and help you get those patients' data back into the database. So who's best qualified for the job? I think the most important thing is these people need to have a passion for vascular access care. So the best person is ideally a dialysis nurse background, or somebody who's worked in a CKD office for years and really understands these people. It could be a dialysis technician who's got good skills in vascular access examination and is able to pick up dysfunction in patients' access. This person should be visiting the dialysis units on a regular basis, because that's when you will be able to get good physical exams and pick up any problems, and then get those patients referred back to the right practice, whether it's an interventional practice or to the surgery office. There is no one model that fits in every practice. So you may find your coordinator who's predominantly in the dialysis unit 100% of the time, or it could be somebody who works in your office and frequently visits the dialysis unit, or it could be a nurse that works in your CKD clinic, and you task that person to make sure that they do have dialysis visits as well. So which model works for you is based on your practice and what options are available within that local area. So these are our two vascular access coordinators. Currently, Kathy Ballard, the one on the left, she's a dialysis physician nurse. She is a nurse practitioner who has had extensive experience in dialysis patient care for the last 20 years. She used to be a critical care nurse before she joined us as nurse practitioner. And Kaylee on the on the right, she's a dialysis nurse by profession in her previous life, and now she works in a CKD clinic and is a patient liaison in the clinic, and gets these patients educated for vein preservation, and then follow up on patients who've had issues with their access care. So we have a lot of challenges which are frequently based on reimbursement for these coordinators. How do they get time away from the work that is already being assigned to them so that they can do this additional work? How do we coordinate the care between various places of care in our ESRD patients? There is care in the dialysis unit, there's care needed in the hospital, the surgeon's office, the interventional unit. And I think those are really the things that we really need to focus on. And then once you're able to figure your problems in your center, then we should start focusing on how do we coordinate care at a more regional level, at a more national level. And that's where I think the studies that we're talking about here, the vascular access surveillance study, may help put all of that together to improve patient care. So in summary, I think there is clear data that vascular access coordinator should play a central role. I think it's an essential piece because your mortality directly attributable to vascular access is just too high not to be focused on. So with that, I'll stop and I'll take any questions. Yes, sir. So physician extender is a new term that has come up in the last almost a decade now. So it could be physicians in the United States. We can use a nurse practitioner. And the nurse practitioner works under your license, but she can independently see patients and you know, give clinical care. And there are physician assistants, and they have a different pathway of training. And these people work alongside with you, and they can see patients, and then you kind of, you know, supervise them. So that's a way to try and help alleviate the busy practices. So you can have my nurse practitioner can see 10 patients on her own. My physician assistant can see 10 patients, and I go and make sure that these patients are adequately taken care of. Thank you.